Hello there, this is Dr. Mintz. These are two CTs, one performed on the patient's arrival and the other performed 2 days later. This is a 78-year-old male who was found unconscious, believed possibly to have had a myocardial infarction, and so this is the CT obtained on admission, and not a whole lot to really talk about here. Increase the contrast a little bit. 78-year-old can have some low attenuation in the hemispheric white matter, which is a normal aging process. We see some low attenuation here in the posterior limb of the internal capsule right here, and that's probably the corticospinal tracts, which often are lower in attenuation than surrounding tissue. But otherwise, if you look at the gray-white matter differentiation, it looks pretty much intact. We have a lot of beam hardening artifact here. The patient was obviously unable to cooperate well. We do see a thin, high attenuation area, a ribbon-like structure in the cortex, which indicates the normal expected distribution of attenuation in cortex, with a thin, higher attenuation cortical area and a lower attenuation grayer area of white matter. So you could argue that, well, we're not having the same amount of gray-white matter differentiation as you usually see, but I think that's a hard case to make, because here you can see white matter with cortex right next to it, and there is a significant difference. If I increase the contrast, you can really see very well a cortical ribbon here. Now, with anoxia, asphyxiation, heart attacks is one example, you can lose gray-white matter differentiation, especially in the motor cortex, which would be in these areas here, and in the visual cortex, which would be medial occipital here. And this may be artifact or a small amount of that early ischemic process. When you look at the subsequent study, this is really clearly had advanced. This is 2 days later, and you can see that there is an overall abnormally low attenuation to the hemispheres. Still kind of grainy because of the fast scanning that was used. Presumably the patient is still struggling and moving during the scan. But if you look for the gray-white matter differentiation, you see some areas which are still visible there. But if you go up here, you see large swaths of cerebral cortex where you really cannot identify the gray matter from the white matter. Large areas, some of these that are little high attenuation areas, may in fact just be artifacts related to this beam hardening artifact, which is probably accentuated by the patient movement. So you have this loss of gray-white matter differentiation, and it's hard to find good examples of that, so I'll give you a chance to kind of look over around here and see that here you do have some gray-white matter differentiation, and here you don't. Plus you can see that there are cortical sulci still visible here in that frontal region, but they are much smaller than were present on the earlier scan 2 days earlier. So not only is there gray-white matter differentiation, but there is clearly loss of the cortical sulci, which is called sulcal effacement, and sulcal effacement generally represents diffuse cerebral edema. And so we have cerebral edema due to the anoxic injury, which has caused substantial areas of cell death. Now, the basal ganglia are particularly prone to anoxic injury, and that's why they usually stand out from the background, as you see here with the caudate nuclei on both sides and the putamen on both sides, caudate and putamen, both showing very low attenuation. Here you can see the internal capsule defined by the caudate putamen, and globus pallidus is in here, and it's probably partly affected. It's difficult to separate from the putamen, but here it looks like there is still some intact globus pallidus, but it's a little hard to tell. This is where the thalamus is located, and it's not as vulnerable to anoxia as are the caudate nucleus and globus pallidus. Here you can see that predilection for involvement of the visual cortex, both occipital lobes medially, which is where area 17 is located, the calcarine cortex, which is where we find visual cortex. Okay, here you can see how high attenuation the pituitary gland is compared with the brain, and that's because when you window the images for visualization of gray levels in the brain, you bring down the window level enough that relatively normal soft tissue structures like the pituitary acquire a higher attenuation. Now, this high attenuation here in the region of the middle cerebral arteries looks quite different than it did here, and that is because it looks almost like subarachnoid hemorrhage, and that's because you have high attenuation blood vessel in this region, and what's against it, what's immediately adjacent to it, is this ischemic edematous brain, which provides a contrast of normal vascular relative high attenuation from the low attenuation brain that is anoxic injury. And that's actually the reason that the falx stands out so much more on the later image. It's more contrasty, a little bit in this case, due to that lower attenuation of the hemispheres. It just stands out a little more loudly, and then if you window them differently, a little bit more prominence here. So this is a case of an adult with an anoxic encephalopathy with very subtle changes possibly present on this early scan, but in 2 days we see very classic characteristic findings of anoxic encephalopathy with loss of gray-white matter differentiation, sulcal effacement of the sulci, that is, and particularly low attenuation involving the caudate and putamen, representing cell death in those areas due to the anoxic insult.